Good afternoon, everyone, and welcome to the valedictory session of the 15th conference hosted by the Center for Public Policy at IIM Bangalore. We've had two and a half very exciting days of the conference touching on various topics, but we'll talk about that later. Currently, it is my honor to welcome Dr. Soumya Swaminathan, Chief Scientist at the World Health Organization. Thank you very much, Doctor, for so graciously agreeing to give this talk at such short notice. You agreed so quickly, and what must be a particularly busy time for you and WHO right now. Let me formally introduce Dr. Swaminathan. Dr. Swaminathan is the Chief Scientist at the World Health Organization, heading the division created to strengthen the organization's scientific work and ensure quality and consistency of norms and standards. She has also been previously Deputy Director General for Programs at WHO. She is a pediatrician by training with long experience and globally recognized researcher on tuberculosis and HIV. And she has worked throughout her career to translate research into impactful programs. Most recently, Dr. Swaminathan was Secretary at the Department of Health Research and Director General of the Indian Council of Medical Research, ICMR. From 2009 to 2011, she has also served as coordinator of UNICEF, UNDP, World Bank, and WHO's special program for research and training in tropical diseases in Geneva. She has sat on several WHO and global advisory bodies and committees, including the WHO expert panel to review global strategy and plan of action on public health, innovation, and intellectual property, the strategic and technical advisory group of the global TB at WHO. She's also served as co-chair for the Lancet Commission on TB. She's received her academic training in India, in the United Kingdom and USA, and has published more than 250 peer-reviewed book publications and chapters. Thank you very much, Dr. Swaminathan, for agreeing to give this valedictory session, and I will turn it over to you now.
Good afternoon to everyone, and thanks also to Professor Rishikesh and Dr. Sriram for this invitation. I had a look at the program, and it's very diverse, the topics that you're covering, but I think a lot of it is very relevant to the impact that this pandemic is having on people's lives, because one of the things, of course, that's become very clear is that it exacerbates inequalities and inequities. And what I would like to do is to talk to you a little bit about where we are in the science of this virus, what we can expect over the next months and years, but also would like to touch upon the pandemic as a learning opportunity for us to face other threats to our health and to the environment and to society, and how really we should be looking at strengthening systems and improving resilience so that we can face such future events. It's clear that this may be the biggest pandemic in our lifetimes. Obviously, the previous such a huge event was the 1919 influenza pandemic, which is often called the Spanish flu, even though it didn't originate in Spain, but that name has stuck. That is estimated to have killed about 25 to 50 million people globally. It was right after World War I, and at that time, the population of the world was, of course, much lower. So it killed a huge number of people. And the difference now is that science and the tools we have, the technological tools we have, are obviously very different, much more advanced. In fact, there's even been a question of whether the flu pandemic was actually flu. Now, this time around, of course, within a few weeks of identifying this new syndrome of pneumonia, atypical pneumonia, which did not have any of the known pathogens turn up positive on the tests, the scientists in China were able to identify and sequence the whole genome of the new SARS-CoV-2 virus. And on the 12th of January, this was actually made public. So this actually, the speed at which this happened, obviously, has a huge impact on the response. And the main thing was that we were able to develop diagnostics within 24 to 48 hours of the whole genome sequence being published. And that vaccine developers also started working on vaccines within a couple of days. And that is why today we see, and I'll talk a little bit about vaccines and where we are with that. So starting in January onwards, we knew at the WHO that the focus needs to be on science, on research, and on global collaboration on these topics, because that's the way we would be seeing an end to this. And so we very early on convened global experts, scientists, researchers, academics, to start looking at all the different topics and areas, starting from the origin of the virus itself, what the animal host could be, how it jumped to humans, what is the transmission routes, what's the epidemiology, and then clinical manifestations, how do you prevent it, what's the prevention and control measures, as well as research on vaccines, therapeutics, diagnostics. And not to forget, we also set up a working group on social and behavioral sciences and one on ethics of different topics around the pandemic and its response. So the working groups were set up in February. They've continued to work. We reconvened in July, virtually, of course. We had over 1,300 people at that meeting. We had 400 the first one in February. And it was clear that we've made huge advances in our knowledge. We've learned a lot. We understand transmission much better now. We understand the epidemiology of the disease. We're still learning about things like, what happens in children. So the impact, how the disease actually infects children is a very important question, because around the world, schools have been shut. It's estimated that something like 1.6 billion children are impacted out of school. And obviously in the poorer communities, this has a very negative impact on learning, cognitive development, but also on just the social fabric of those communities. Parents can't go to work, etc. So it's clear now that children can get infected. They do get infected, that younger children under 5 tend to spread it less than older children, but older children spread it as efficiently as adults. The good thing is, of course, children get less sick, and very small percentage of them end up needing hospitalization, and a very, very tiny percentage of them develop multi-organ inflammatory syndrome, which is a rare complication. But in this pandemic, we see clearly the relationship between age and severity, and between comorbidities, or what we call the non-communicable diseases like hypertension, diabetes, heart disease, dementia, being risk factors for severe illness and death. And so it's disproportionately affected older people. But also in the US, for example, they started seeing that a risk factor like obesity could very well play a role in young people. So young people felt generally quite confident that they wouldn't get sick, but it's not true, because if you have other risk factors, smokers, obesity, etc., then that can also make young people aged a lot. And we see mainly that it's younger people, infections in young adults, that are driving the epidemic, whether it's in the US or in Latin America or in Asia. And so the mortality rates, luckily, are not going up. We see the second wave happening in countries like Spain and France now, where after opening up, the transmission increased again, but the mortality has stayed very low. So that's a good thing. It's partly related to the age of the age group of people who are now getting infected, as opposed to the ones in the earlier March, April phase, where a lot of the elderly, a lot of people in care homes, nursing homes were getting infected and dying, at least in Europe. But this time around, it's different, and there could be other reasons also related to the virus, to the environment that impact the epidemiology. And there's been a lot of discussion why the mortality rates are relatively low. Again, probably related to the demographics, but it could also be other factors like the other infections that we are exposed to, and other viral infections, etc. We don't yet know the answer to why South Asia and Africa in general have seem to have much lower mortality rates than what we saw observed in Europe and in North America. Now, obviously, the pandemic has also impacted, we talked about education, but it's impacted the health system in many, many ways, because the lockdowns that were imposed did result in a complete disruption of essential health services. The WHO did a survey in about 120 countries, and we found that 80% of countries that responded told us that essential health services were disrupted in more than one domain, starting with immunization services to antenatal care, to essential surgery, to treatment of diseases like tuberculosis, malaria prevention programs. All of these saw an impact of anywhere from 30 to 80%. And so, cancer, these are all things that are going to, we will see the impact of this in the coming months, both in mortality, excess mortality that happened during this period, but also in terms of the health status of individuals who were not able to get care during this period. So what does it mean in terms of a health system really being able to prepare for something like this and be able to respond? We have talked about a possibility of a pandemic. There have been many papers written about this. There have been many warnings given by different agencies around the world, and the WHO has been talking about preparing for pandemics, for health emergencies. Even if they're localized, they don't have to be pandemics, they can still impact. And India has many such situations where you have annual outbreaks in different parts of the country of either known or unknown diseases. We had Nipah virus 2 years ago. We have the encephalitis, which occurs in children in Bihar and UP every year. We have many outbreaks of diarrheal diseases and other infectious diseases, which are sometimes known or unknown. So unless you have a system of surveillance, strong surveillance, where you're able to pick up these etiology and find out the etiology and immediately address the issue, this can easily become something which goes out of hand. And that is why we do have the Integrated Disease Surveillance Program, the IDSP, which may have its weaknesses, but essentially was set up really to have this kind of a surveillance at the district level and below, and also be able to respond. Now, of course, one of the challenges we have is that we do not have, I'm talking specifically about India, but this applies to other countries as well, a public health cadre that is basically devoted to issues of public health, which include not only the detection and response, but also prevention, management, training, capacity building, and looking at other risk factors for disease. So the environmental risk factors, social and economic risk factors. So I think one of the important issues really is to have a model public health administrative architecture for states. And there are only a couple of states in India that have that, a separate Department of Public Health with a separate cadre. This is something that the National Health Policy 2017 does talk about, and it needs to be implemented. It should be decentralized, but at the same time integrated into the health system, and of course should achieve convergence, particularly in data. Data streams from different parts today end up in different places, so they cannot be effectively utilized for a response. There should be minimum governance norms and standards for this public health architecture, which should be determined by the central government, obviously, but then a nodal agency in states with good governance indicators and a rights-based public health law could be some of the innovations that one can think about, particularly looking ahead and responding to this pandemic. The other thing is, of course, legal laws which could be helpful. And the Vidhi Center for Law actually has put out a very good report on what the existing laws are and where we should really think about new laws. And this may be something which is of interest to you all to discuss further. And for example, we have the Public Health Emergency Preparedness and Response Law, the Epidemic Disaster Act of 1897, which is still valid today. And of course, we have the Disaster Management Act of 2005, which is what is being invoked now. But again, a law which delineates the powers and functions, a communication and command structure, defines what public health emergencies are. It safeguards the rights of individuals, empowers states to create rules, and sets aside a percentage of the budget for public health emergency preparedness. Would be, I think, a very positive step as looking forward in preparing for future. The other, I think, important factor that's played and had an impact on how countries and states have responded really is the participation of people and communities and populations, and how decentralized the health system is, and how close the health system is to the communities, and how good that communication is. And this is something we've been talking about also in when we talk about primary health care. Often the missing link, very often, healthcare is looked at as a delivery of health services from the supply side, but on the demand side, there is less attention paid, and the role of individuals, families, communities is extremely important, because obviously health is not just something where you treat diseases, but if you want real well-being, then you have to attend to nutrition, to housing, to sanitation, to water, food, all of these other things, and risk factors like tobacco, alcohol, air pollution, all of these play an important role. So communities have a role to play, and wherever there has been this kind of a decentralization of power, devolution of functions, this facilitates community participation and has been shown to be effective in the long term. If you want a sustainable response, then one has to do it this way. And then on the usage of health data, obviously there is a data protection legislation now that is under discussion, and there should be an element of being able to streamline the use of data, especially in health emergencies. And one can bring in certain rules and regulations just during the period of a pandemic in order to help the government to respond. Now, how long is this going to last? I mean, this is often a question that I'm asked and we are asked. And of course, we don't have a crystal ball to predict. But what we can say is that the flu pandemic lasted 2 years, 1918, 1919. Of course, it had a huge loss of lives associated with it, mortality. And that is why we are working on a vaccine, because that's the only way probably to bring an end to the acute phase of the pandemic. I don't think we're going to looking at eradicating this virus. It's very firmly established in the human population now. It's going to continue to probably be there at a low level, but then it becomes like another virus that we live with. Influenza, we have outbreaks every year, but it's manageable. There's a vaccine. It's not 100% effective, but if enough people take it, then at least the vulnerable populations can be protected. So here again, there's a huge amount of work that's gone into vaccine development. Over 200 candidates in development, over in phase 3, which is the last stage of clinical trials. So by early 2021, we should have some news about, I hope, a couple of candidates that are effective, even if not all of them. And then, of course, is the big challenge of being able to scale, being able to produce enough, being able to distribute, and most importantly, being able to have a fair and equitable distribution or allocation mechanism so that populations in all countries get this, or at least the vulnerable groups get it. And we don't have the situation that we had in 2009, where a few rich countries had cornered most of the doses of the vaccine as well as the drugs for H1N1, and the poorer countries were waiting for a long time. Luckily, that pandemic didn't turn out to be very serious. But this time around, WHO has been focusing on a lot of discussion with all our member states in order to come to some consensus on how we do a fair distribution. So if you start with limited number of doses, we're going to have probably a couple of 100 million doses to begin with, not the billions that are going to be needed. And so you would have to distribute it either to healthcare workers, frontline workers, the elderly. There's a system of prioritizing who should get it, and everyone, all of these people in all countries should get it at the same time. That would be the ideal situation. There's obviously quite a lot of funding that's needed. We estimate about $31 billion is going to be needed for the vaccines initiative alone. Therapeutics and diagnostics have their own needs. So about 18 billion of the 31 is actually needed before the end of 2021. And so what we're appealing to countries is that you're actually losing out trillions.
Yeah, so we were talking about vaccines and the fact that we will have limited doses in 2021. And then, of course, India is in a good position because we have a large number of companies that are working on vaccines and quite a number of candidates which are under development. Some are in collaboration with those companies outside, but some are also local innovations. So that's very good. It's creditable that so many candidates were also advancing in India. And India is obviously a manufacturing hub for vaccines. It supplies something like 40% of the global requirement for childhood vaccines. The other challenge, of course, is going to be that most countries have experience with childhood immunization programs. There are very few adult immunization programs globally. So to get this vaccine out to people who need it, like we talked about, those who have comorbidities or older people or those who are in risky occupations, etc., that's going to need quite a lot of planning, and it's going to need both policies to be developed and also a lot of practical planning and systems by which this immunization can be carried out. So maybe the last few minutes, I would like to say that the other big threat to all of us, to mankind, of course, is climate change. And I must say that the two are linked because we know that viruses that jump, species barriers and jump from animals to humans, it is much more likely when, their natural habitat is disrupted because of climate change or urbanization, etc., where there is meddling with wildlife, where there's illegal wildlife trade, where, there is farming of wild and domestic animals, where the markets are not segregated, etc. And of course, urbanization itself is a risk factor just because of the density of population you have in cities. And that's why you see this pandemic really impacting cities disproportionately, especially the mega cities, because of the density and how that impacts transmission. So climate change is slower, of course, and therefore maybe it was neglected by a lot of people as well to have its impact. It's not as dramatic as a pandemic, but certainly it's one of the defining threats that we face, that we all have to respond to. And so this is a good time actually to think about, how do we build back better or build forward better? Some people like to say, what are the things that we can do differently? This is one of them. I think conferences, reducing our carbon footprint, cutting down on travel, doing things using digital technologies is certainly one, but there are many other things we need to think about. And And as we think about how we're going to expand universal health coverage to make sure that everyone, regardless of the ability to pay, is protected. And universal health coverage, again, as I said, is not just about delivery of health services. We have to look at it more holistically and think also about health promotion and prevention. And very often those are actually more difficult because they are not things that the health ministry or departments are responsible for. They cut across different sectors, and therefore it has to be really an all of government approach, because there are policies in every ministry, every department that impact health. And so the health ministry really becomes an advocate for health, but very often the action is in other sectors. So the investments in universal health coverage need to be increased, and as I said, the health security aspect that we've been focusing on now can only happen if there's also investment in the other elements of universal health coverage. So they're like two sides of a coin, really. You can't have health security without having a good health system, and investment in preparedness has to go hand in hand with investments in response and in management of chronic diseases. So maybe I will stop there, Hema, and turn it back to you to see if there are any one or two burning questions that you might want me to take. You're muted, Hema. Can't hear you.
Yes, yeah. Thank you very much, Soumya. Fascinating and timely topic. Really playing out in different minds, and better to address this than someone like you with your training and your right now. There are a couple of questions, so let me do one. I think would probably appeal to the larger section. One is this, there seems to be this kind of a debate between, not a debate, two sides talking about efficacy of vaccines versus letting the epidemic run its course and amongst the community and achieving herd immunity. Is it either or? I mean, what is the scientific reason?
There is no way to get to herd immunity other than through vaccines. I think that's very clear. All scientists would agree on that, because there is no disease for which human beings have achieved herd immunity naturally. Mm-hmm. There are viruses, of course, that keep circulating that have been around for a long time. And there are diseases like measles, which used to kill a lot of people till there was, big vaccination programs. So I think to achieve herd, I mean, I know that now the sero surveys are showing that, X percentage of the population has antibodies. It may be 10% in some places, 20%, it's less than 5% in some other places. So there's still a huge pool of susceptible people out there, and the infection will just go on and on. So I think it would take years and you would still not achieve herd immunity. So I think clearly we need vaccination. What percentage of the population needs vaccination? Our best guess is 65 to 70% to achieve that herd immunity.
All right. Also, someone's asking about, giving a global overview from where you are sitting, the African continent. In fact, how has it impacted on the African continent? I know South Africa has been quite heavily impacted. We haven't seen much about the other countries, at least not in the news reported in this part of the world.
Yes. So Africa has been, it's been relatively late to start, and it was slow to increase. And as you say, a few countries like South Africa, Nigeria, Ethiopia are the ones that are reporting more cases. Of course, initially the problem there was the lack of diagnostics. And there were only 2 labs in the whole of Africa that could do this PCR test. And we very quickly had to work with the countries. And within a matter of few weeks in February, we had at least 1 lab in every country. But of course, that's not sufficient. So I think testing has been an issue. And so there's probably underdiagnosis. But we've also seen that Probably it's related to, the public health system being geared up for many infectious diseases, because Africa has been dealing with HIV, with TB, with malaria, with a number of infections, with Ebola in some countries. And so they have that knowledge of, how to respond. Of course, it's difficult in the cities, just like in India, some of the big cities, where there's overcrowding and things like that. But it's also the demographic, right? Africa, like India, has a very young population. And so there could be a lot of asymptomatic infection there, which has not been picked up.
Right. So would you then say Kerala, because also they had, we get now so much about their health infrastructure, their ability to deal has also come from experience. Right? They've dealt with viruses in the last 4-5 years quite well.
Yeah, no, definitely. And the fact is that even the high income countries, where this started, actually struggled to cope, because many of them have dismantled, their public health infrastructure over the years. There's been less investment in public health, more investment in perhaps in clinical facilities. And so now they're rebuilding that. People are actually hiring more staff, whether it's UK or Germany or Spain, these contact tracers and other people that are needed to do on the ground, public health surveillance and response are being hired afresh. And so this is not something where, the high income countries coped well and the low income didn't. In fact, it's sometimes you see it's a reverse.
Right. I think at least the US experience is showing that countries are not necessarily doing very well at all. The WHO has sort of a global body. What WHO do now to say steer global governance? We talked a little bit about global governance and thinking about health system. I mean, it's an advisory body. Do you think countries are now taking WHO more seriously and listen to what's coming, or can the WHO have a more direct role?
So that's related to the constitution of the organization. And as you pointed out, it's an advisory body. It's made up of member states, and the rules and regulations are set by the 194 countries. Now, as you're probably aware, there is an independent panel that's been set up to look at the response to the pandemic, both the response by WHO as well as in general, by countries as well. This is co-chaired by Helen Clark and Ellen Sirleaf Johnson, the two ex-leaders of New Zealand and Sierra and Liberia. So the panel is going to begin their work soon, and let's see what the recommendations are. Because at the moment, WHO does not have the kind of powers that some people expect that it should have, where it could actually tell countries what to do or go in and do inspections and things like that. Not set up like that. Basically an advisory body, and every country, every sovereign government has to then implement it the way they want to. So we'll have to wait and see if that's going to change or not.
I know you've had a bit of a time, so let me ask you a final question. Coming closer to you, given your intimate knowledge of India and our health infrastructure, or the lack of it in some places, how would how do you roll it out in India in terms of the people of it? But more importantly, you started off talking about inequalities and then about distribution of the vaccine, right? So say the next 3 years, if you had to lay out priorities, what would they be?
Your voice was breaking, so I couldn't hear the whole thing. What was the last bit you said? Lay out priorities for?
Indian policymaker in terms of dealing with I stopped my video, hoping that will better the connection.
Yeah, that's better. Yes.
Lay out top 3 priorities for the Indian government and hopefully terms of dealing with this?
Well, I think I mentioned a couple of them, but data is very important in a situation like this. You really need both timely and accurate data on disease prevalence, how it's spreading, also on mortality. There's a lot of discussion in many countries on mortality and how do you measure that and how do you. So the medical cause of death registration in India is very, very low, even though something like 80% of deaths may be registered. The medical causes of death are entered in only 20% or so of those. And so there's a huge gap there and a need for improvement, because it's not just for this, for COVID, but generally, unless you have a good vital registration system, birth and death registration and causes of death, the government does not have data then information on the burden of disease and what people are dying of. So that's an investment that should be made for the longer term. But data, as I said, in general, we need to look at how it can be, the various data sources can be made to converge, and this can be used then, by using modern analytics, artificial intelligence, a lot of things can then it can be applied really to inform what's going on. The second is investments in the health system itself, and I think the government has committed to increasing the investments percentage of GDP in providing for universal health coverage, particularly at the primary healthcare level. That's where we really need strengthening, this whole concept of family and wellness and health and wellness centers, the sub-centers, which are now health and wellness centers, the focus on health promotion, prevention, as well as management of chronic diseases. These are going to be really important to improve the quality of life, but also the healthy life expectancy. Because, we measure life expectancy, you can also measure healthy life expectancy. And in India, there's a gap of about 10 years between life expectancy and healthy life expectancy, which means that there are a lot of chronic diseases that people live with in the latter part of their life. And that means earlier, like hypertension and diabetes. So the second would be the investments. And the third would be, I think, the human resources that you need for health. Because obviously it's not enough to have infrastructure. You need trained cadres of health workers, not just doctors, but the nurses, the pharmacists, the lab technicians, the rehabilitation people, people who can do palliative care. There are many aspects of healthcare today where we don't have the required physiotherapists, people, especially at the peripheral level. So there needs to be a mapping and an investment in producing that human resources, and then, of course, enabling them, incentivizing them to work at that level. And then I think to look at the last point I would say is investment in R&D, in research and development, particularly for diseases that disproportionately impact our population, and to find innovative solutions, affordable solutions for those problems. Of course, these are both communicable and non-communicable diseases. So we need much more investment in research, not just clinical research or epidemiological research, but also health systems research, implementation research, or implementation science, as it's often called, because that's the one that really enables the health system to become a sort of a learning health system, to do some innovations, to study it, to learn from it, to adapt, and then to scale. So hopefully that concept is now picking up. We know of randomized trials that are being done for medicines and drugs, but also things like what JPAL does, for certain policy interventions in education and health, etc. So a lot more thinking needs to go into what do we need what are the challenges that we are facing, and how can researchers, academics actually work with government and help government to answer some of those questions. Thank you.